All right. Hello, everyone, and welcome to the Greenspace Health, the inaugural Greenspace Health and Yale Measurement-Based Care educational panel series. I want to take a second to thank everyone that's attending for being here, for taking the time out of your day, for your interest in measurement-based care. We have been overwhelmed by the interest. When we first launched the first panel and open registration, we were transparently, we were looking for hopefully 100 people to sign up, clinical leaders, clinicians, to learn about measurement-based care, to hear from the experience of our great panelists. We've had over 375 people register, which is just, to be honest, mind-blowing. And I think speaks volumes around the interest in measurement-based care, the momentum for measurement-based care, and the desire from people within the industry to look forward to innovation and change and improvement. So thank you very much for being here and taking the time. There's a question in the chat if this is being recorded. It is being recorded. Panelists can be seen are being recorded. The audience is not. So you can throw anything you have in the chat, but you're not being recorded yourselves. Overall, I think just to start with some context setting, I think we've made so much progress over the last decade within mental health and behavioral health overall in regards to shame reduction, stigma reduction, the ability for families and friends to support their loved ones or the people that they care about when they're struggling with their health, and having an opportunity for them to learn more about how to do that if they'd like to. Whereas, 5 years ago, there just wasn't that much opportunity or that much content for you to take in to actually learn that. And I think with measurement-based care, we have an incredible opportunity to mirror that change within behavioral health services and mental health services. And that's super exciting, I would say, largely because of the impact that measurement-based care can have. Before I jump in any further, I'll introduce myself. Hi, I'm Jesse Hayman. I'm the Chief Growth Officer of Greenspace Health. And as I mentioned, very excited to be here with you. When you think about the impact that measurement-based care can make, Greenspace likes to think about it as 3 C's, we call them, that are, I guess, key factors as to what's needed when you implement measurement-based care. The first is consistent. And what that means is essentially not checking in with clients or looking to collect patient-reported outcomes every 6 months or 3 months, but on a really regular or frequent basis. So that would be something like every 2 weeks or every 3 weeks, depending on the assessment you're implementing, which usually comes with a recommendation of how often it should be collected. But that it's consistent so you have an understanding of what's happening for your client or your patient, what changes over time are happening, but also why that might be happening, be able to dig into that with your client. The second is customized. And what that means is, I'll give an example of, like, if we work with a clinic and that clinic has an eating disorder program, they will usually choose 2 or 3, whatever works for them, assessments that apply to everyone within that program. So that they can compare across settings and understand what's happening across every client. Let's say, though, there is a clinician who's working with someone that has an eating disorder and also is having large issues with social functioning, let's say. That clinician should have the ability to add a social functioning measure so that they better understand their specific client or patient can understand themselves and what they're going through and the effective treatment a little bit better. And so that ability to customize is really important. The third thing, and I think you can refer this as either option of C's, is client visibility or collaboration. And so that refers to the client actually being able to access their data and see their data in a very similar way to what the clinician would see, so that they're enabled and empowered to understand their mental health, participate in a conversation around their own health in a much better way, bring up topics they may otherwise not bring up with their clinician, and actually improve the discussions they're having in therapeutic lines, sort of thing. When you think about those 3 C's, so consistent, customized, and client visibility or collaboration, you can probably imagine that doing any of those without great technology is really difficult and quite a barrier. So consistent measurement, if you're not able to collect that automatically, it becomes a bit of an issue. Customize, if you can't easily add an assessment and it's on the provider or the clinician to do that, or providing client visibility so that they can actually view something and understand it in a palatable way. So that is where Greenspace came in and comes in, is trying to create technology that allows us to flip the measurement model on its head and make it less about data collection for reporting, so measurement being a data collection process or exercise, and really about measurement or measurement-based care being very first about clinical value and providing clinical value. And then it just so happens that with that clinical value, you have a great ability to report in a way that you never have before. But it's really about providing clinical and specifically client value first. So our job has been to make measurement-based care as easy as possible for clinicians so that they can provide clients with easy access to the data, they can inform the measurement process, and just improve communication, therapeutic alliance, and impact overall, so that every individual can receive better care. I think that said, alongside great technology, with any sort of change, there's a massive need for education. And that's where this partnership between Greenspace Health and Yale Measurement-Based Care comes in. We need to be able to let people know the impact that measurement-based care can make, in some cases just defining it for people, and also understanding how to implement in different types of settings and in complex settings. And that's really what this first panel is about, and it's what all three panels are about. The first panel today is really an introduction to measurement-based care, an introduction to the Yale Measurement-Based Care Collaborative, and high-level touching on measurement-based care across a bunch of different areas at a high level. In the second two, we will focus more on the intricacies of measurement-based care, specific questions that have come up, and that sort of thing. So just a little bit of housekeeping. One, there's a Q&A box at the bottom. We'll be monitoring it. We will take questions, so we'll be compiling them and take them at the end. Hopefully we can get to them all. If we can't get to them all, they will inform the next session. And our hope is that people can attend all three if they're able. The second thing is there'll be a survey that pops up when you press leave at the end of the panel. Please fill it out. That'll also give us feedback on anything we can do differently, but also inform the content of our next two panels. So with that said, thank you for being here. Appreciate you taking the time. And I am excited and honored to kick things off with this incredible panel of experts. And I will just quickly introduce them, but then give them the opportunity to do so themselves. We have Dr. Sandra Resnick, Dr. Jessica Barber, Dr. Elizabeth Connors, and Dr. Amber Childs. Thank you all for being here with me. It's an absolute pleasure. And I will kick it to you to just give us a little bit of an introduction to who you are, your background and experience, and why you're excited for this conversation. So why don't we start it off with Sandy?
Hi, everyone. It's so great to be here. Thanks, Jesse. What a pleasure this is. So I'm Sandy Resnick, and I am a clinical psychologist, as we all are, and I have a background in program evaluation and research in psychiatric rehabilitation, but I learned measurement-based care as a graduate student as part of my psychotherapy training and have used it ever since, and had the opportunity recently over the last 5 years to lead large-scale measurement-based care implementation in a large system, and have become an absolute, just absolutely love talking about measurement-based care, because I think it is just a transformational practice that's accessible to everybody, and really looking forward to talking more about it. Thanks.
Thank you so much, Sandy. Jessica, do you want to jump in next?
Yes, thank you so much. I second Sandy's sentiment. It's great to be here. I am also a clinical psychologist. I am a clinical health psychologist by specialty, and likewise, measurement-based care has just been part of my training and practice from the very beginning. I was a frontline provider for 10 years, and then about 2.5 years ago now, I have the opportunity to actually work with Sandy. So now I get to also have fun working to help implement measurement-based care more broadly across the whole system. But I am still a practicing clinician as well, and I love measurement-based care so much. It helps the work that I do so much, and I'm excited to be here and hopefully help others see how exciting it is and how it really informs care.
Lots of excitement on the panel, and I think that's great. We're all very much passionate about measurement-based care. Hopefully that comes off. And why don't we go to Amber next?
Yes, I will keep the excitement going. I'm Amber Childs. I'm also a clinical psychologist by training, and it is just my pleasure to be able to talk with you all about measurement-based care. I like to always say that I really backed into MBC in some ways, or measurement-based care, but the reality is that my work is a lot about program development, and evaluation and implementation of evidence-based practices. And I think measurement-based care has slotted really neatly into that overall sort of cachet of work. But one of the most important things to me, and I would think many people as clinicians and providers doing this work, is taking any opportunity that I can to really hear the voices of patients and families as we're doing work. And I think that measurement-based care is an incredible mechanism for that. I think it's one tool among many, but that's part of the reason why I feel so passionate about MBC in particular. So really looking forward to the conversation today.
And last but not least, Elizabeth.
Hi, everybody. Thank you so much for having us, Jesse and Greenspace. I'm Elizabeth Connors. I'm a child clinical community psychologist by training. I'm an assistant professor in the Yale Department of Psychiatry. I've loved measurement-based care for longer than I knew it was a thing. I think many of us would agree to that. I've been a mental health clinician and supervisor predominantly in community-based children's mental health with a specialty in school settings and mental health services being delivered directly on school campuses. And then more recently, I've just partnered with a lot of organizations who are looking to implement MBC. So more recently, I've done some research and consultation and evaluation, helping systems, school districts, community behavioral health organizations think through the implementation components. So happy to be here.
Amazing. Thank you, Elizabeth. I will say it again, but absolutely honored to be sitting with you all. And I think you all know that. And just the ability to bring you all together to educate, 300 plus people that are coming. So thank you. I'm going to start with the very basics. We're going to get into like the impact and the benefits and examples of measurement-based care making impact in practice, practically. But I'm going to start with very basic. So I'm going to throw this at Elizabeth, but can you tell us a little bit about why you all started the Yale Measurement-Based Care Collaborative and the purpose of it?
Yes, absolutely. I'm really happy to. So the Yale Measurement-Based Care Collaborative is just simply a working group that's been formed by the four of us here at Yale, where each psychologist and MBC champions in different ways. We actually work across various types of behavioral healthcare systems and client populations. But what's brought us together is this shared mission to really advance measurement-based care implementation, research, and practice with the end goal of really improving mental health quality. So I will also say that a primary focus within our collaborative that I know we all feel strongly about is really emphasizing how MBC empowers clinicians and clients by improving the communication and collaboration. So those 3 C's that you talked about in the beginning, Jesse, is just super mission aligned for us. And that's a theme that you're going to undoubtedly hear kind of repeated throughout our discussion today. I do want to point folks over to our website. If you haven't been there yet, please check it out. We post clinical and implementation tools. We have some measurement-based care demonstration videos that were produced by Sandy and Jessica and team. We have our current MBC projects up there. And if you're into social media, please also follow us on Twitter. We like to highlight the most current MBC research events and clinical tips. We just love getting the word out about this practice, and we see ourselves as just one piece of the puzzle to kind of enhance the communication among the field about this practice.
The other thing I would just add to that about why the collaborative was formed is that measurement-based care helps to improve patient outcomes. Like that's the whole tweet, underscore, highlight, bold. And it's just as simple as that. But the reality is that people are just not using measurement-based care in daily practice in the way that would be consistent with that kind of research. And so part of the work of the Yale Measurement-Based Care Collaborative is to really amplify the practice of MBC, really demonstrating the value of MBC, kind of like what this panel is intended to do, but then also developing and studying processes about how to take the guesswork about how to do MBC in daily practice. And so that's some of the work that we also try to focus on. And as Elizabeth mentioned, you'll see some of those tools and different things like that scattered on the web and Twitter and on our website.
Awesome, Amber and Elizabeth, thank you. I think one thing that just stands out to me is and we'll touch on this later, but you can read a lot of research on measurement-based care and the impact it's having, but I think the value of all of your experience clinically and that you're able to share both from the research side and then practical implementation implications of measurement-based care is massive. So thank you for providing education, for leading the way in this regard, because we know the change needs to happen. And obviously the work you're doing is pivotal to it. I'm going to, again, go to the basics, and I'll pass this over to Sandy, but sometimes you would think that like measurement-based care is still in its earlier days. There's a ton of momentum growing, but I think there's also still a gap in people understanding the definition of measurement-based care, and sometimes equating measurement or general measurement to measurement-based care. And so I wanted to take some time to allow any of you, but we'll start with Sandy, to just talk about what measurement-based care is, general definition, but also from your perspective.
Yeah, absolutely. And we find that a lot too, even in systems where we've been doing education and training for years. It takes a while for everybody to get sort of on the same page. And so we often do repeat the basics because they're not basic to everybody. So I think that makes a lot of sense. So we have sort of some formal definitions that we use, the use of quantitative data, repeated throughout treatment in order to help with treatment outcomes and track progress over time. But one of the catchphrases, if you will, that we use is collect, share, act, which we find can be a really nice short way of communicating a lot of information and helping people remember all of the important parts. So collect means that you're collecting a measure. And we personally endorse what are called patient-reported outcome measures. And the reason for that is because we feel that getting the patient's voice or the client's voice in the room is the best way to start this process. So you may hear other people talking about measurement-based care using clinician-administered measures or other sources of data. And our point is not that those other sources of data are inferior. They're great. And we certainly think that there's a place for them. But when we talk about measurement-based care, we're specifically talking about these patient-reported outcome measures, and sometimes abbreviated as PROMs, but we're going to try not to use the abbreviations to make sure everybody knows what we're talking about. So that's collect. And then share involves making sure that you're sharing with the client exactly what it is you just collected, and having conversations about that information and making sure that you're on the same page. And then the last piece is act. So you can't just share it back and not do anything with it. Then you want to make sure that you're using that information to make important shared decisions about the treatment encounter, about the treatment plan. And the collaborative process of the collect, share, act process really allows the client and the provider to transparently collaborate about what treatment should be, what's working, what isn't working, what might need to change. And so that's basically it in a nutshell.
And so I actually usually work with teenagers. I'm also a child and adolescent psychologist, which is why I have a particular affinity in working with Dr. Connors in this group. But I'm imagining, if I were to tell a teenager about MBC and I used anything like collect, share, act, they'd be like, Dr. Childs, you're canceled. In fact, I did get canceled once when I told a teenager what my Instagram subscriber count was. But when I talk about MBC with teenagers, what I say is, MBC, measurement-based care, is using data about what you say is happening so that we can get curious together about your treatment and our work together. And then we're going to use that information together as a team so that we can make decisions about how we're going to solve problems and about what happens next. And I tend to get a lot of mileage out of that description when I talk to teenagers about why we're going to be using data and what does this all mean.
And I would just say that at the heart of it, really, measurement-based care is just making sure we're pausing and asking one of the all-important questions, which is, how are you doing right now? But in a systematic way. And anybody who's a clinician here, I'm sure you have this experience of getting to the end of your session and realizing you got swept away and you didn't cover something you really meant to. And so sometimes we can forget to step back and ask that question. Clients can as well. So really at the heart of it, it's making sure we're asking, how are you doing? How is this going?
I really appreciate, I think, like the definition from the clinical perspective, but also stepping into the shoes of a client or patient and figure out how to define that for them. Because, collect, share, act is fantastic on the clinical side. Then how do we think about that in regards to the way we introduce it to patients and clients, which is something we'll touch on in regards to, I think, people's concerns around client engagement and how that works. And obviously, I think those definitions on the client side are really important, or the way to explain it. I mentioned this a little bit earlier, but I think the research to real life gap, if you will, or the research to clinical gap is not just in mental health or behavioral health, but across the board is always large. So, we can find out the benefits of something, and I can talk about, as well as all of you, the benefits of measurement-based care for days, and, its effect on patient outcomes, its effect on therapeutic alliance, reduced dropout rate. But that doesn't speak to the ability to actually implement it in practice and then see the benefits of it. And I think that's, to me, the greatest part of this panel is our ability to lean into like real life examples and that sort of thing. We wanted to start basically going from research to implementation. Now that we have the ability to do it in a fairly easy way, what you have all seen as some of the more significant benefits of measurement-based care in action. And maybe we'll start with Sandy, where we can talk about actual clients and actual examples versus, research-focused numbers.
Sure. Yeah. So one of the things that I really love about measurement-based care is that it's really trans-theoretical. It's just a good foundation for just about any treatment that you're providing. And so it fits onto lots of different evidence-based practices, or pretty much any kind, as I said, any kind of service that you're providing. In terms of examples, I'm kind of old and my memory's not so good. And so what's funny is that some of my first clients are actually more vivid to me than maybe some that I had a few years ago. And I was just sort of remembering one of my first clients on internship with a really significant panic disorder. And she had symptoms that she felt were really debilitating, and it was really limiting her day-to-day life. And new therapist, I got myself a protocol, and we did amazing work together using measurement-based care to track her progress. And it was such an amazing example of being able to really use the measures at every session and follow her progress and know where maybe we needed to focus on each session, what was sort of going on. But what was so helpful to me, again, as sort of a new therapist, was in termination. And so she and I had a great rapport. She was so grateful for the work. And it was really hard to think about, how am I going to broach this termination piece? And the measures and the progress that she was making kind of did it for me. She could see her own progress, know how well she did. And she kind of knew that it was, it was time, that she had made such great progress that she was going to be able to stand on her own 2 feet and do this, of course, knowing she could come back if she needed to. And so for me, as a relatively new therapist, it provided me both feedback about the fact that the work we were doing together was helping. It provided feedback to her that the work she was doing was helping, and then gave us a foundation for having that difficult conversation that maybe the work was done. So that was what I was thinking about. I don't know what others are thinking.
Awesome. Thank you, Sandy. I think this is from a personal perspective in regards to any sort of mental health struggles, also talking to people that access in-person care. I think one of the hardest parts for me is communicate or understanding what isn't communicated. And so often people can only share with their clinician what they're able to understand. And I think there is quite a gap sometimes as people, especially when they're in care for the first time, begin to understand themselves and what actually might be leading to things, or even what they're going through, even what, let's use an example, what anxiety feels like, and their ability to communicate that to their clinician. I think that's something that measurement-based care is really helping, is a clinician to see something that a client may not be able to communicate, or giving clients access. And the client visibility side is clients beginning to learn about things they would otherwise not have been able to communicate. So I'm going to throw this over to Amber, but in every discussion we've had, you have very much expressed your passion for the patient's role in the clinical process, or the client's role in the clinical process. And I'm hoping you can share some of your thinking around the impact the measurement-based care has on higher engagement and the understanding the way it can help clients understand their own mental health.
Yeah, that's such a great point. I agree with you. This is part of what underlies the passion, is really just prioritizing collaboration and partnership. I think that those things are definitely core to measurement-based care, but I think, as Sandy was saying, they're fundamental to any aspect of this work that we're doing. And I liked some of your remarks, Jesse, around sort of having patients be able to access more about themselves and to kind of come into more understanding about what might be happening. I had this great supervisor once who talked about this idea of insight. And, there are lots of things we can think about that, but you sort of can't hand it down, right? It's something that the person has to experience and arrive at and kind of problem solve and process. So if data can help us take a shortcut there or provides a roadmap to that, I'm all for it. I think it makes things sort of concrete for folks and they can get their arms around it. But in terms of this idea of accessing information that maybe the patient might not have been aware about, and MBC doing that, I have just this great example. I work primarily with teenagers in a group-based setting, so an intensive outpatient group-based setting. And the great thing, and also the challenging thing about that, is that group-based services with teenagers means that, teenagers are able to say things to each other that like adults don't get to say to them, and teenagers are able to say things to each other that adults don't get to say to them. So every Monday, we would have the teenagers complete their measurement, their MBC measurement, and then we would have a review group to talk about those data the next day. Like that's how we did it in the IOP. And so there was this youth that we were working with, and every single Monday, she would not show up to treatment, but she would show up every single other day. And then the next day that we had the review group, she would have a blank graph to be looking at. And so this is group, right? So we're all talking about our scores. We're getting curious about them together. And then eventually a teenager was like, what's up with that? Why do you always have a blank graph? And then another teenager then said like, yeah, like you come every other day, but you just like don't come on Mondays. And so eventually the teenager was able to say like, well, I just don't like to fill out the measure because I'm worried about what it's going to say. I don't want it to say something that I don't like. And another person was like, oh, like how you don't show up to rehearsal for drama because you're worried about like saying the wrong thing or like making a mistake. And so then I'm literally watching this happen. It's such a powerful moment where somebody has now used measurement-based care as a template for understanding potentially avoidant behavior or something that was getting in the way of something in real time that was happening for this youth. So then we were able to make a game plan about, wow, I wonder if we can use this to understand. So it was almost like the absence of data was data, right? So that's why the process of MBC is so important. But we also think about this differently too, where, every interdisciplinary rounds, we're looking at these data for our teenagers. And so eventually we would see, weeks 1 through 3 of this 6-week program, anxiety scores would decrease weeks 1 through 3, week 4 would kind of stagnate. And then week 5, we would see this big, huge jump up in anxiety scores. And a teenager, we were like, can we get curious about this together? What do you think is happening? And this youth was able to say like, well, it's COVID and I've been able to sort of not have to go to school from 12 to 3:30. And I'm usually by myself all the time. And I'm just getting like, I'm feeling some type of way to put it in teenager terms about now being by myself after school. And it's not that I like you guys, but I don't know how I'm going to cope with that. So then we as a program started to think, is there a way that we need to build in additional skills to kind of process and manage that separation and termination in this COVID context? So those are some of the ways that we've really thought about that process being critical.
Amazing. Thank you, Amber. I think one of the things I love about what you're saying, and this goes back to the idea of like flipping measurement on its head and making it a clinical benefit first. And then it so happens that we can use that to inform programmatic change. So you start at the clinical level, there's, effect on the youth that you're working with. That can lead to a programmatic insight, programmatic change. And hopefully if you step that up one level further or one level lower, is then system can change based on information coming from different programs and sharing and collaboration across different types of services and that sort of thing. And then it goes right back to clinical value and providing value to that client or patient, which I think is massive. One other area I wanted to chat through, and I'm going to throw this at Elizabeth, is like you're very focused on school-based mental health. And I think with working with youth, that often means in a collaborative care setting. And it's not just with youth, there can be collaborative care settings across many different types of populations. But you've spoken around about the benefits of measurement-based care, not only to the client, but to the people that are there supporting them throughout the process. So I just wanted to throw it to you and see your thoughts on, I guess, the effect of measurement-based care on everyone else in the care process.
Yeah, absolutely. Thanks for that, Jesse. And it's so important because we know that our clients don't exist in a vacuum, right? They're nested in family systems. They're nested in, their school environment, their home environment, neighborhoods. They're also maybe receiving care from this care environment. There's so much going on in the ecology of the individual sort of identified client that we're working with. And one of my favorite things about MBC is it actually brings a lot of value to not only the client, but all of the stakeholders surrounding that client in their natural ecology. So just a couple quick examples. I actually conducted a study a few years ago where we asked clinicians at the beginning of implementing MBC, this was a brand new practice for them, what sorts of barriers did they forecast would come up for them in doing this practice? Sort of after their orientation, we told them all about what would be involved in collecting and using these measures. And they most frequently said that they were worried about damaging rapport, especially with parents, but also with the students that they were working with. And interestingly, then we surveyed them again at the end of the school year after they had had some implementation experience. And it turned out that that was actually the least frequently reported experience. And so we saw that, in fact, some clinicians reported that not only did they not see a damage or a rupture in rapport, but it strengthened that rapport and strengthened that relationship. And I had school-based clinicians I work with and consult with just last week tell me, we've had parents call us and say, hey, I'm concerned about something going on with my student. And I thought I would give you a call as the clinician because I know that you're the person that I can talk to about their progress. And clinicians have said to me, school-based clinicians, if I never called and talked to the parent and did that measure over the phone and checked in with them to say, how do you think your student is doing? I don't think they would have picked up the phone to call me. So it provides an opportunity to build a bridge to, especially in children's mental health, to make sure that parents are involved, members of the process. It also gives us nice perspective on changes over time. When you see those graphs over time, it can really help young people and their parents and other collateral raters, like if you're working with teachers, to have some perspective on how they're doing now versus when they started. This comes up in schools a lot. There's some tricky times of the school year, coming back from spring break is one that's kind of relevant right now. And sometimes teachers and parents might say, what's going on with, with this student? They are just having such a hard time. But if you can point back to those graphs and say, actually, look where we were at in October, November, and how much progress we've made, it can really give more perspective and help build some patience and empathy, but also celebration to see that trajectory. And then the other type of stakeholder that I think is worth mentioning are system leaders and the partners and stakeholders at the system level, because MBC really shines a light on what is happening in mental health care. I don't think we have a lot of opportunities for that. It makes more transparent and visible the good work that is happening with clients every day. And so I've been involved in a number of evaluations of measurement-based care implementation, and particularly for school-based mental health, where sometimes those providers get questions from the school system about why do you keep pulling these students out of class to provide mental health services to them on campus? But when we can use MBC as a tool to communicate what's going on and how effective those services are, it really can help partners understand what it's about and the outcomes, as Amber was talking to, and making sure that those are underscored. So MBC, I think, brings value to a lot of folks within kind of the whole ecology of the client, not just the client themselves.
Awesome. Thank you, Elizabeth. I'm going to pass it right off to Jessica because I think it rolls right into Jessica. You spoke about the idea of we in care quite well on a call that we had a few weeks ago. And so I just want to let you talk about the importance of it, but also your perspective on it.
Yeah, sure. So this is my favorite part of measurement-based care, actually. When we're thinking about any kind of mental health treatment, it really should be a partnership or collaboration between the clinician and the client. And so that means that in addition to asking the question I mentioned a while ago of how are you doing right now, and how are you progressing, we have to also ask the question of how is this going? How are we doing making progress on what's important to you together, and are we doing that? And I'm glad you asked about a clinical example, because I actually met with this particular client literally just a couple hours ago. So she's someone I had been meeting with. I do CBT, so we're doing CBT for anxiety and depression, but she also comes with a history of trauma. And she's a fantastic candidate for CBT, really utilizing the skills, really developing insight, and doing all of the work that you should be doing. And we would see improvements on her measures. I always use the PHQ-9 and GAD-7, and we'd look at her measures and see improvements, but then we'd see worsening. She backslide some, and we saw it over and over. It's what I call the toothy graph. So we'd be looking at this together, and we acknowledge that we're seeing this up and down pattern, and let's talk about what might be happening. And one of the things that we really were able to understand together is that a lot of our work kept tapping into trauma. Past trauma was impacting her current experiences and creating a lot of anxiety and depression. And so we were able to use this as the springboard into asking the question, and I mean this quite literally, asking, how are we doing together? Is this approach the best one for you right now? Are we meeting your needs? And she was able to gain insight that actually, no, it wasn't the best approach. We really needed to think about something else. And so she ended up choosing to go into a trauma-focused treatment. And so one of the things that I love the best about this is, instead of me sitting here saying, how am I going to fix this? How do I get this back on track for her? I actually ask the most important person in the room, the client, and say, what are we going to do? How are we going to adjust? And the thing that makes me so excited about having met with her literally this morning is that I was looking at her data, and she's just wrapping up her trauma-focused treatment. And since September, the teeth are gone. There's no more teeth on that graph. So I couldn't wait for her to see it and to talk about all of the progress that she made. And with the exception of one tiny little bump where there was something really remarkable going on, her PTSD scores came down because her provider was using a PCL5, so I could see that. And her PHQ-9 and GAD-7 scores were coming down. There was one little bump of scores related to a stressor, but her PTSD scores did not go up. So she was excited, and I asked, what are your thoughts about that? Does that match, and how do you feel? And she's like, I was thinking that this was the case, but it's so great to be able to see it. And she said, these were her exact words. She said, I feel happy and I feel confident, and like I'm not getting stuck with stressors for 2 weeks. I'm able to just move forward so much more quickly. And so it was just an amazing experience, and you see it, you just see it on the graph.
Awesome. Thank you so much, Jessica. I think it's a great example of just the client and the clinician being able to be on such a great page, and the data help inform the care process overall and where treatment goes and that sort of thing. With any change, and I think measurement-based care is a pretty big change to the industry, you have early adopters, and then you have a second group that's maybe not eager to be first at the gate, but is there and excited. A third that is probably open to it, but has some worry or questions, and then a fourth in any significant change where people that are just not open to it. I would say probably most of the people attending are in group A, B, or C. So I want to take some time to highlight some of the biggest questions we get, or the most common questions we get. And the first is really, and it's actually in the chat as well as one of the Q&As, is will clients engage? And I think people are worried that they won't. And so I want to throw this to Sandy and just hear your thoughts and others on engaging clients and what you've seen as in regards to how they engage.
Yeah. The answer is yes, they will. Okay, so we're done. No, just kidding. We do hear this from time to time, this worry, and it's understandable. But what we've learned over time is that when there's value added, when the process provides value for the client, which I hope already you've been convinced that it does, that clients will absolutely engage. And for us in our collect, share, act world, that means that the collect absolutely has to be paired with share and act. You have have to make sure that you're sharing and acting. And if you believe in the process, if you believe that this is going to make the difference that we're telling you it is, then your clients are going to believe that too. But again, it's about creating value. And for me, I had a bit of a light bulb moment about this, sort of like putting it in a metaphor that sort of I could understand when I was starting to do a lot of this training and hearing a lot of these concerns from clinicians. And I was traveling a lot, so I was drinking a lot of Starbucks coffee, and I'd get my coffee, and usually within a couple of hours, I'd get an email from Starbucks. This was years ago. Fill out the survey about how we did, and I would look, and I saw that I would get 10 stars if I filled out the survey, and I'm like, I love the stars, and so I would fill out the survey, and I'd get my stars, and I was really happy. And then they stopped giving stars. I'm like, what? So they would send the survey, but I got nothing. Why would I fill out the survey? I got nothing. Like, I don't really care about Starbucks that much. I like the coffee when I'm traveling, but I don't want to do it. And that was my light bulb moment about value. And so the whole collect, share, act is about making sure everyone gets value, that we're not just collecting a measure for a checkbox, for a requirement, for, somebody told me I have to collect, and then the measure goes nowhere. Making it meaningful, first of all, creates a better experience for you as a provider. It also creates, obviously, the incentive and the meaning for the client. And so it all has to go together. And when you do that, clients will absolutely engage.
Thank you so much, Sandy. I'm going to jump into sending this to Amber, and I think we've touched on this a little bit already. So it's one thing if they will engage, but I think the strategy of how to approach introducing measurement-based care to a client really matters. And so I'll pass it to Amber. Just if you could share a little bit about how you go about introducing it to different clients.
Of course, absolutely. So as I've mentioned at the top, I tend to work clinically with teenagers. And so this is a crew who is usually not doing cartwheels to come into care or to come into treatment. They oftentimes feel like some adult or other power has mandated that they're going to do this. And, we have a 6-week program and they're like, we're going to grow old with you. How could we possibly? So I really pitch MBC as the opportunity for that teenager to be in the driver's seat of this treatment. So again, it's not about what Dr. Child says or what your mom says or what the school therapist says when they saw you in the hallway. It's about what you say is happening, and the data are going to be the thing that we hold out in front of us both together to kind of be looking about that. And so I, as I said, I get a lot of mileage out of this. And the other thing that I'm really careful to do is I frame this, especially teenagers are really tuned into this idea. And I think adults can be too, around performance. Like somebody's going to be measuring what I'm doing. Is there a right or a wrong way to do this? The language in teenager life is like, is this a test? And so we talk about like, this is not a test. This is just an opportunity for us to take really seriously what you have to say. And we might not agree necessarily when we start to get curious about this. We might not necessarily agree about how we're seeing things, but I'm going to be taking that seriously. Your treatment team is going to be taking that seriously. And ultimately, we want to use every opportunity, I think, as Sandy and others have mentioned, to really have that person's voice come through and be an active part at the table, including about potential ways that we might be seeing things differently. And I know Jessica is like a master in terms of the rationale.
Well, I don't know about that, but I do think that it really does come down to the rationale. How we set it up for clients at the beginning makes all of the difference. I think that with any treatment, we want folks to know what we're doing and why. And we talk about alliance a lot, and it's not just rapport. Alliance is really, are we in agreement about what we're working on, why what we're doing is going to be helpful, and so on. And it's no different with measurement-based care. So ensuring that we're explaining, we're using measures, here's how we're going to use them. Here are the logistics, here's how we're going to use them together. But I think that it can also go deeper than that. I started to have clients spontaneously tell me, this was years ago, that they use the measures as a way to check in with themselves at the beginning, right before our session. They would sit down and it would be their sort of own personal self-reflection. And it would help them come up with priorities and remind them of things that maybe they weren't thinking about, but that the measure kind of prompted them, like, oh yeah, we should talk about that today too. And I will say that it took me an embarrassingly long time to realize that I can actually encourage them to do that. So I'd like to do that and actually almost reflect or convey to them that really our session starts when you fill out the measures, because that's when you really start to think about what we're going to cover today. And so doing that process and taking time with it and making sure we're engaging them from the start, it just makes the experience so much more meaningful and just authentic.
Amazing. Thank you. I think, oh, sorry, go ahead, Amber.
I was just going to say so quickly, what are the sort of entire enterprise that we're really thinking about is empowering people, not just in treatment, but when they move beyond treatment. And one of the really key things about what Jessica said that I want to just amplify is that, she has patients that are using this to reflect before they come into care. Imagine when people finish their treatment, if they have the tools to be able to use that process, not that we expect somebody to do a PHQ-9 in their basement or something, but if people are using that as a template to like move throughout the world more effectively, how much more powerful can you get in terms of an intervention? So just to really amplify what she just said.
Awesome. Thank you very much. Another big one that comes up, and I think this is really probably the biggest change for service providers, is that we're now suggesting in measurement-based care is providing data to clients. Patient-reported outcomes, so they've told you what they've given you that data. But I think there is often a discomfort that people have with, wait, is there any risk in providing this data to them and letting them see and learn about their own mental health and the ups and downs of symptom change? So I'll throw this to Sandy. I'm curious if you could share your thoughts on any potential risk within sharing data with clients.
Yeah. Oh, I'm so glad you brought this up. We used to hear this all the time in the beginning of our implementation, and especially from psychologists. I don't know how many psychologists there are out there, but we were all trained to do psychological assessment. And psychological assessment is so structured, and oftentimes there are, the secret questions, and it's confidential. Like, you don't share raw data. It all has to be interpreted, and that's all legit. Like, I hope it doesn't sound like I'm dissing any of this. Like, that's really important in psychological assessment, and making sure the tests are private and used responsibly, and not, sharing test items or test data with clients. This is not that. This is not psychological assessment. And so, for those of us who were used to psychological assessment, it sort of takes a shift. But we talked about these as patient-reported outcome measures, and often they're super brief. Many are in the public domain. Anybody could Google them and just take them themselves. And what we're basically doing is we're saying, giving people these face valid questionnaires, how are you feeling? They fill them out. They say, here's how I'm feeling. And then in the process, by giving their data back, you're saying, here's what you said you were feeling. So there's no trick to it. There's no massive interpretation. It's just what it is. And once you get comfortable with that, and it just opens up so many doors for creating a shared language about talking about difficult things, for you having the language about, here's what you said. Does this sound right? So I think it's about a mindset and recognizing that the clients already know how they feel. You're not telling them something that they don't already know. And if for some reason it is sort of, a new experience for them, it's something they could have done anyway on their own. So I don't see that as risky. In fact, I think it's empowering.
Amazing. Thank you, Sandy. Elizabeth, and I won't throw it to you here, but I think you've made a good point in the past and Sandy, you touched on this a little bit, is they know the data, they gave you it, and how empowering of a process can it be to actually start to have them understand it a little bit better and use it to make changes in their life and understand what may have a negative impact or positive impact on their overall health. So thank you for that. One question that also comes up is the impact of data in the measurement process and how that could get in the way of clinical expertise and making it less, it's more about a data process now and less about people's individual clinical expertise and understanding their client and that sort of thing. And it is something that has come up a few times as a concern. And Jessica, you spoke well to this. So I'm curious if you could share with us a bit of the balance between clinical expertise as well as data within the clinical process.
Sure. Yeah. I mean, I really just see measurement-based care and the data that we get from it as being a tool. It's just one of the tools that we have at our disposal. And so if, somebody came up to me and they said, I have this thing and it's going to make your job easier, it will help your clients progress faster, it's going to empower you, empower them, I wouldn't say, I've got good clinical expertise and good training. I think I'm pretty good at what I do, right? But I would say, I want that. Give me that. And that's really what I see measurement-based care as. It's a resource, it's a tool, and it actually informs the clinical impression that I'm making. I'm assimilating it with all of the other data that I have, whether that's from the chart or what the client has told me. So it helps to formulate that judgment, but it never replaces it.
Amazing. Thank you, Jessica. And I'm going to throw it to Amber here. You brought up dancing in regards to measurement-based care. And I'd love to just throw it to you a little bit to talk about what dancing has to do with measurement-based care and clinical work.
Well, one, it has nothing to do with my skill. I almost wish I hadn't made this metaphor because I'm not a great dancer, but I do think, measurement-based care is a little bit like choreography. So you can learn, any person can learn like the steps to choreography or a sequence of movements, but choreography is not the same as dancing, right? Dancing is an art that's brought about by the artist's interpretation of that particular choreography or those steps. And so I think, the dancer really brings it to life with their skill and their expertise and their training and their trial and their error. And so the psychotherapist, right, in this metaphor is kind of like the dancer. Their skill, training, expertise, and knowledge is really what gives life to the choreography of something like MBC, in the same way that it gives life to things like CBT or DBT or MOUSE, whatever it is that you might be using. And so it cannot be performed well without a strong clinician. So to Jessica's points, that it's really a tool and a guiding framework for people to use, but it really relies on providers and clinicians and patients, of course, to do it well.
Amazing. Thank you, Amber. I'm also not quite the dancer, but enjoy dancing nonetheless. I'm going to throw to the Q&A. And I know we had a few more questions we were going to go through or we were thinking about covering, but there's been a lot of questions, so I want to make sure we get to them. And at 5 minutes, so at the hour, I'll let people know you can log off if you need to, but maybe we'll go 5 minutes over and then shut down from there because there are quite a few questions. I'm going to start with this one from Antigone Darcini. And it's, I'm wondering about how measurement-based care has looked for marginalized communities in particular. What kind of barriers to implementation you've noticed? And I know that, Elizabeth, we had a conversation about this and you're doing some work in particular. So I'll throw it to you, but if anyone else wants to jump in, please feel free.
Yeah, thank you. This is such an important question. So thanks for highlighting. And I know it's something that, we're talking about within the collaborative very frequently these days, and just really understanding how we can ensure that the patient-centeredness of MBC is seen as something that can help us promote collaboration, shared voice, and treatment relevance and acceptability with our marginalized and historically underserved populations. The other piece that I want to kind of circle back to for a moment here is the rationale or introducing the concept of measurement-based care to people. I think Sandy and Jessica also talked about this, how important it is that we communicate why we're using these measures and how these measures will be used and how they won't be used. So for any population that's been historically marginalized, or even just if you've had an experience in healthcare where you felt like you were not heard, right? And so you kind of come with this expectation that this might not be fully about you or what you have to say, but rather this is an expert in front of you who is going to make some interpretation and recommendations about your life, right? So measurement-based care really helps us turn that piece around. And as Amber was highlighting, kind of spotlight and amplify the client's voice to say, you actually are in the driver's seat here. And our treatment process will adjust to what it is your needs and your kind of specific tailored goals are for moving forward. So that's just a little bit about, I think, how we think about it. I don't want to speak for everybody. I don't know if others want to jump in on that.
Amazing. Thank you, Elizabeth. I'm going to go with another question here from Janine Quintero. And this is, for those of us that work with adolescents and collaborate with caregivers around treatment, would you share the adolescent score with the parent, or would you just focus on the parent scores? Our organization uses a pediatric symptom checklist, which is both a self and caregiver report. Thanks.
Such a great question. I'm really happy to touch upon that very briefly. So two things. When we're working with teenagers, caregivers absolutely have to be a part of the treatment. I think the literature speaks to that really clearly. But this idea of like who's getting access to what scores and how, when we talk about the rationale, we talk about MBC as a process up front, that is already part of the conversation with the youth and with the family about what that communication pathway will look like. But we use our measurement-based care scores in family meetings, right? Like mid-treatment, we'll bring that in and look together with the family at the trends along with the teenager. And that can actually be a really powerful intervention in and of itself for caregivers, particularly in our setting where youth are coming off of maybe an inpatient stay or maybe sort of really have intense resources even before they come to us, and caregivers might be feeling sort of hopeless about what changes can happen. We make that an active part of the care, but it's really about that conversation with the youth and what all is going to be shared and how you would move through that. So we definitely include it. And caregiver report is also an important element to think about when you're working with youth populations, because they may see things or observe things differently than what you're able to understand from the youth themselves.
Thank you, Amber. Before we hit the hour, if people need to log off, you can. I'm going to ask a couple more questions and then wrap up. But if you do have to log off, feel free to go ahead, but hopefully we can keep you all for 5 more minutes. So the next question is, have you seen or could you see this being implemented with case managers as the primary practitioner or only for clinicians? And I think maybe that's something that comes up because we refer to clinician quite a bit, but if any of you could take a stab at answering that.
Yeah, I think I will. And in fact, yes, the answer is yes. But what I would, because again, remember that these are patient reported outcome measures. These are not super complicated measures. And so as long as everyone is trained in how to use the measures and the measures are within somebody's scope of practice. So for example, if you're not a licensed practitioner, you would not probably want to be giving a PHQ-9, for example, where you're assessing for suicide, unless there is ready access to somebody who is licensed who might be able to do a suicide assessment, and that there are clear standard operating procedures for how you might use that information. But if you're using quality of life measures or functional measures or, sort of standard other measures that aren't really providing risky information, I think they're wonderful for case management. The thing you just want to be careful about is making sure that the measure is within the person's scope of practice as well as the treatment that they're providing. So you don't want to assess something that the provider or the case manager or the whoever isn't actually going to be able to do anything about. We call that, making sure that the information is actionable. Now, actionable could mean that you're referring to somebody else. So that as long as there's somebody to refer to, that's okay too. But you don't want to assess something, find out that there's a need or an interest or whatever, and then not be able to do anything about it because everyone's going to be frustrated with that. So again, just to summarize, thinking about scopes of practice, making sure you know how to refer if necessary, and that the measure is useful to the treatment that's being provided.
Thank you, Sandy. I'm going to ask one more, and this may be a similar response, but a different question. Working with interdisciplinary teams in our mental health system, we often receive feedback that measurement-based care is very psychology focused. Can you share ways you've bridged engagement across disciplines? Examples, social work, psychiatry, nursing. And that's from Debbie Emberly.
I'll just say super briefly, and then I'm curious to punt it to Amber because I know she's worked on a lot of multidisciplinary teams, as we all have. The vast majority of my implementation supports and what I've learned from measurement-based care is actually with social workers. So I would say that my experience has been different. I've been kind of the lone psychologist in the room where the primary clinicians providing usual care mental health services, especially in our public mental health system, that charge is usually led by our social work staff. So shout out to social workers who do awesome MBC work every day.
Yeah, and just to add to that, I work primarily in interdisciplinary team-based settings. And so working with psychiatrists, social workers, psychologists, pharmacists, nursing, psychiatric nurse practitioners. And so milieu counselors, so individuals, just as Sandy was speaking to, who are not clinically licensed but are still participating in the treatment. And we all are understanding the Collect, Share, Act process, knowing how to understand and interpret those measures. I mean, the most beautiful thing is when you have, the front desk patient coordinator saying like, yeah, I noticed that, the scores were getting a lot lower. And that's when they have that appointment coming up with Department of Children and Families, right? So, I mean, we're really all looking at those data and understanding them together within the context and scope of our own roles and what that looks like for the patient. But if the psychologist wasn't there, MBC would still be alive and well in that setting.
Do we have time for another quick comment?
Go for it.
So we've done some surveys, and the fact of the matter is psychologists do tend to have more favorable attitudes towards MBC. And I think, again, it's because of our experience in psychological assessment that we've learned. But we also work with interdisciplinary teams, and again, just everyone can do measurement-based care. So I do think that's perception as opposed to reality, that, there's a place for measurement-based care in all of the services we provide. And so it's part of what we're doing with things like this and with the work that we're doing, is to make sure everyone understands that measurement-based care really is for everyone.
All right, we are 4 minutes over time. I think there's been fantastic questions. And as I mentioned, those that we didn't get to will inform our next panel, as well as the feedback that you give when you log out. So please take a few minutes to fill that out if you can. And honestly, just thank you so much to everyone in attendance for your interest, for your interest in measurement-based care, but also your curiosity and obvious engagement throughout in the chat and Q&A. And Sandy, Jessica, Amber, Elizabeth, thank you so much. This is just the beginning. To one of the questions that was in there around the next two panels, we haven't announced the dates for the next two, but it is a 3-panel educational series where we'll dive deeper each and every time. So thank you all. Appreciate you taking the time. Happy Friday, Good Friday if you celebrate. And if you ever have any questions around implementation or solutions available, Greenspace is around to have that conversation. Also, the Yale Measurement-Based Care Collaborative is around with tons of supporting information that you can check out on their site or our site. So please take a look and reach out anytime. And on that note, I hope you all join us next time. Have a fantastic weekend shortly, and please join us next time, and we'll send you an email to everyone in attendance with that next date. But thank you, and have a great rest of the day.